Hey folks, this is Beth Wright, and I'm providing you the podcast for Chapter 2, Unit 1 of your Pharmacology NUR 136. Okay, so this one I can tell you now is going to be rather lengthy, but it's got all very, very important information in it. So you might want to get you some popcorn, Coke, and sit down and just listen in and get your notes and follow through. Okay, so if you can see there in the picture, our main objective when we're given medications is that we want to be therapeutic with our patients. We want them to be therapeutic with their medications. That's our main goal, and it's to promote desired effects and minimize adverse effects. And so in order to do this, we must understand the whole concept of pharmacokinetics and pharmacodynamics that happens with the patient. We must account for potential sources of individual variation in drug responses from the patients and tailor the regimen to the individual. On a basic level, drugs are chemicals that alter basic functions of the cells. The drugs get in the body, it gets it done, the job that it's intended to do, and then gets out. But on a more microscopic view, we have to think about actually how does that drug get to the targeted cell via the circulation and then out of the body, out of circulation. So, you know, there's a lengthy process there. So the drug gets to targeted cells by circulation and then out of circulation to the targeted cell, then getting through the main door of the targeted cell or the cell membrane and doing its intended purpose, and then getting the heck out of Dodge, returning to circulation, and then getting out of the body. So that's kind of what we're going to be talking about today, and this is one of my favorite parts of pharmacology. So hopefully it's going to be very important that you understand these concepts for sure. And you see the little girl there looking into the throat of another little girl, and probably a sister. And, you know, we want to prevent minimal harm to the patient. That's our main thing, is minimal harm and maximum benefit. Okay, so we got to talk about the cells, because that's, you know, how the drugs get to, you know, how they get there, and the cells at the target area. So all of this is very important. So just a little bit of review for the cellular physiology. We know that cells are dynamic factories. They take in raw material and manufacture products required to maintain our body function. They deliver those manufactured products to the appropriate destination within the body, and they differ from one tissue to another, like cardiac cells versus the muscle cells versus the liver cells. So they all differ, you know, in how they react and how they respond. So this is a picture. It's in your book on page 18. Well, I don't know if the picture's on page 18, but the box that goes through cellular function is on page 18 in box 2.1, and just review that just so you can remember, because you've had this before. So just review that so you can remember specific things about cells and what happens as far as you know, normal cellular function. When we talk about medications, we're going to talk quite a bit about cellular membrane. So that's one thing that's involved here. So, continuing on with a little bit of physiology on the cells, we know that they can exchange materials with the immediate environment, and they get energy from nutrients, and they can duplicate themselves, and they definitely communicate with one another via biological chemicals, and that's a pretty cool concept and how that does. And those biological chemicals also help with the drug therapy as well. So when we're talking about drug transport through cell membrane, they can reach and interact with cell membranes to affect cellular function. And when we think about the effects of medications on the body, we need to be aware there's kind of two types of effects. So one is a local effect, meaning that it acts mainly at the site of application. And just giving you an example of this, so let's say that you have, it's springtime, we know that poison ivy is prevalent right now, so let's say we have some poison ivy, allergic reaction on our skin, okay? So we get some topical medication, cortisone, or maybe it's Benadryl, diphenhydramine, and we put it on that area of our skin. Okay, so that medication is acting locally right there at that site of where we applied it. Okay. Another example of a local effect. So let's say that we get a really bad cut and we need to have some stitches, some sutures to, fix the cut, to put the skin back together. So they will inject medication at that site to numb it for pain. So we can stand a needle going through the skin, pulling the skin together. So that is a local effect. Now, on the other side of that is a systemic effect, and that's when medications are taken into the body and it's circulated through the bloodstream to the site of action and eventually eliminated through the body. But we get a systemic effect at that point. So this would be an example of medications that's taken by mouth, medications that we inhale, medications that are given IV in the vein, medications that are given subcutaneously in the skin, such as insulin or heparin. So they have a systemic effect. And just think, when you hear that word systemic, think system, the whole system. And that's important because we want to know about medicines that affect the whole system versus a local effect. Because we know if a medicine affects the whole system, the way we assess that patient and what's included in that assessment is going to be much more and much different than what we would assess if we have a medicine that's affected on a local level. Okay? So just trying to put that into perspective for you. Transport pathways and mechanisms move drug molecules through the body, and so there's several that's we're going to talk about, and it's also in your textbook as well, and so we'll talk about those in the next few slides. So this is a picture in your book on page 19, and I'm sorry, once again, I'm not sure what page the picture's on, but the box 2.2, page 19, goes through this whole transport, drug transport through the cells. And so if you'll read through that, to get a greater understanding, but we're going to talk a minute about it. So remember that cell membranes are primarily lipid, and so medicines that are lipid soluble, meaning they're fat soluble substances, can enter a cell by just dissolving right into that membrane, and it diffuses directly through it. And that's a good thing. That means the drug is it's going to get there quicker without too much work involved. This is referred to as direct penetration. The greater the lipid solubility of a drug, the more readily a molecule of the drug will pass through the membrane. However, there's not a whole lot of drugs out there that are lipid soluble. There's some, but there's not a great deal. Okay, protein channels is another method of how drugs are allowed to pass through the cell membrane, but they have to be small molecules to do so. Because the protein channels, are not that big. So they have to, again, be small molecules to go through those channels. And, when you think about a channel, it's like there's a gate there opening and closing, allowing, those molecules to enter. Carrier proteins are substances that allow drugs to pass, kind of like a piggyback ride, okay? The drug attaches to the protein and piggyback rides to the cell and through that cell membrane, okay? And so, there's lots of drugs that will do that. So our biggest protein in the body is albumin. Okay, and what you'll see when you read about this and when you study different drugs, what you'll see it's saying is that the drug is protein bound or it's protein binding. So that's what you'll see when you have this kind of transport going, and that's what that means, is that it'll piggyback onto the protein. Now, the thing about that is, if it is a protein bounding drug or binding drug, then that means we have to have enough protein in the body for that to be there, to do the piggyback riding. Okay, so that's going to be important with that. We have other types of things that the way drugs get transported through the body, and we're going to be continuing to talk about it, but these are your main ones thus far. Okay, so pharmacokinetics. What does that mean? So it is derived, that word is derived from two Greek words. Pharmako means drug or poison, it's a Greek word, and kinesis is movement, okay, or motion. So put them together, and it's the study of drug movement throughout the body, and it also includes the breakdown or metabolism and drug excretion. Okay, so there are 4 basic pharmacokinetic processes, and we're going to initially describe them as the movement throughout the body. Okay, so let's start with the first one there. Absorption is defined as the movement of the drug from its site of administration into the blood. Now, we'll talk further about how absorption involves the breakdown of medicines, but as of right now, we're talking about the site of administration, okay, with absorption, and then it goes into the bloodstream, moves into the bloodstream. Distribution is defined as drug movement from the blood to the interstitial space of tissue and from there into cells. Metabolism is defined as the enzymatically mediated alteration of the drug structure, meaning that basically it's being broken down. And then excretion is the movement of the drug and their metabolites out of the body. So now by applying the knowledge of pharmacokinetics to drug therapy, we can help maximize desirable effects and minimize that harm. To maximize beneficial effects, we must achieve concentrations that are high enough of the medication to elicit the desired responses. And to minimize harm, we must avoid unnecessary high concentrations. So the balance is achieved by selecting the appropriate dose and dosing schedule, which is done by the prescribing person. But we have to know about that. All 4 phases of pharmacokinetics involve drug movement. Okay? Now, when we think about ways that the drugs cross the cell membrane, there's passage through the channels or pores, there's passage with the aid of the transport system, and then there's the direct penetration of the membrane itself. So as you learn about specific drugs, and we'll do that in Unit 3, starting Unit 3, you'll see the whole pharmacokinetics section of each drug. You'll learn about that. They'll list it for each drug that you learn about. And so all of this will be available per drugs. So let's dive into our pharmacokinetic phases. So first is the absorption, and that is the onset of drug action that is determined by the rate of absorption. So factors that affect the rate and the extent of drug absorption includes the dosage form, the route of administration, and we're going to talk a little bit more about that here in a minute. The blood flow at the administration site and the GI function. Okay, so we got to think about better circulation of blood, the better the absorption. So things such as pain or stress that causes an autonomic response will cause an altered blood flow, and that can cause a decrease in absorption if we're having problems there. You know, GI function, okay, so absorption, if we're taking a pill by mouth. GI function, most meds are absorbed in the small intestines. So if you have someone who's having small intestines or stomach problems, not just small intestines, but stomach problems as well, then they may have a slower absorption rate. So we got to look at the way we're giving it, the route, and then that blood flow of that. The blood flow, you know, when we think about giving a shot, an intramuscular injection. Okay, again, if your blood flow at that area is not good, then we may have problems. If we give a topical medication, if the area has problems, you know, with blood flow to that area, then the absorption of that medicine may not be what we want it to be. Okay? Presence of food and other drugs definitely is going to affect that the way the medicine is absorbed, and so we'll learn about ways that we can work with that so that drugs are absorbed appropriately. other drugs are going to compete with medications. So we'll talk more about that in a little bit as well. But that definitely can cause problems with absorption of medications. And then the first pass effect. So I want you to just think about the words of this, okay? So this is not for all drugs, but there are several out there that this happens with, and it'll tell you as you study the drug that it is a first pass effect. So when you hear that, what that means is some drugs go through a first pass effect. When the drug is absorbed in the small intestines, it goes to the liver before entering the circulation. In the liver, the drug is metabolized to an inactive form before it enters the circulation. It's a big hurdle for these drugs with the first pass effect. And if the first pass effect reduces the amount of active drug released into the circulation, the dosage of the drug will have to be higher to get the job done. So that's why some dosages of drugs are higher when giving by mouth versus by IV. So when we think about that whole first pass effect, again, medications are taken by mouth and they're shuttled via a special blood vessel leading to the digestive tract to the liver, where a large amount may be destroyed by metabolic enzymes in the so-called first pass effect. Other routes of drug administration bypass the liver, entering the bloodstream directly or via the skin or the lungs. Okay, so basically, first pass effect means that it first goes, it goes into the stomach, but it goes to the liver and it's metabolized, and then it goes into the bloodstream to do its job. Now, dosages and dosage forms and routes, I promised we'd talk a little bit more about that. So what we're referring to there is the type of medication given and how they are administered, the route, okay? So, of course, the dosage is the amount of medication. So you usually see that in milligrams or grams and that kind of thing. The route is an oral medication like by mouth. It's tablets, capsules, liquids. Sustained release and coating. Coating means like an enteric coating that helps protect the stomach. Sometimes you'll see aspirins that have enteric coating. Sustained release means that the drug's gonna last a long time. So you'll see most of the time, not always, but most of the time, the drug will be labeled with SR or CR, controlled release, and so that means, like one that comes to mind is OxyContin. Okay, so OxyContin is a pain medication that is a controlled release, and it's meant to last like a 24-hour period. And several drugs come as a sustained release, time release, controlled release medication. The big thing with these are, many times for medications, we sometimes have to crush the medications because of patients having difficulty swallowing. However, never, ever, ever, ever crush a sustained release medication. Never. Okay, because that definitely can impact the absorption of that medicine. The patient can get way too much medicine too quick, and it can kill them. Okay, so definitely never crush a sustained release. Also, we shouldn't crush enteric coated medications because the enteric part of that is gone and it does no benefit for the patient. So those should not be crushed as well. So oral medications can be given orally, sublingually under the tongue, buccal in the cheek. Topical meds, creams, any kind of lotion type thing, transdermal, meaning across the dermal, the skin, vaginally, rectally, in the eyes and the ears, and of course the skin. Inhalation is the nose or the lungs, so like nose spray, Flonase. Right now people are experiencing allergies, so Flonase is an example of that. Or for the lungs, like a lot of people who have lung issues have to do an inhaler. Also, this can include your nebulizing medications that we sometimes nurses give, or you might see respiratory therapy in the hospital setting give this. And then parenteral medications are your intramuscular, subcutaneous, and intradermal and intravenous medications. Okay, so the fastest and faster routes of medication administration and getting the job done is your IV, your sublingual, or your inhalation. Okay, so that's the way. If medications need to work fast, that's the way we want to give them. Now, with absorption, please understand, as well as with all pharmacokinetic phases or stages, adverse effects, side effects can happen with any of these. Okay, side effects or adverse reactions are effects that we might anticipate, we might expect. They could happen, they may not happen. But anyway, they can happen in any phase of pharmacokinetics. And we got to know them, and we got to be watching for them. Okay? And we'll talk about that more at the end. So just be aware they can happen. Okay, distribution. Now, so we've got our medicine in our body. Our absorption has happened. Now, we're talking about distribution. So how do we get the drug to its destination? Drugs are carried to the target cells by passive diffusion, facilitated diffusion, and active diffusion. Okay, so let's talk about that. Passive diffusion is movement of molecules from an area of high concentration to an area of low concentration, and it requires no external energy for that. Okay, facilitated diffusion is when molecules are combined with a specific carrier molecule, and they have a quicker accelerated diffusion. It's from an area of high to low concentration, and it requires no energy. And an example of that is glucose. Active transport is where molecules move against concentration gradient, and just think about, we're swimming upstream in a river, okay, and it of course is going to require more energy. Your passive diffusion is the most common when a drug moves from a higher concentration to a lower concentration. Okay? So drugs are carried by the blood and tissue fluids to the action site, also to the metabolism site, and then also to the excretion site. So let's step it through here. Once a drug gets absorbed, the next stage is this stage, distribution. Most often the bloodstream carries those medicines through the body, and during this steps, again, side effects can occur, so be alert to them. And we want to, be watching the whole body. If it's a systemic medication, we got to be watching that whole body. So for an example, we take something, let's say we take ibuprofen for pain. Motrin for pain. We're having pain in one of our muscles, and or let's say we're having a headache, okay? And the target organ may be a sore muscle in the leg, or it could be the head, okay? But irritation to the stomach can be a side effect of ibuprofen, so because it's hard on the stomach. So that's an example of how these side effects can occur. Many factors influence distribution, so you got to think about that. Remember about medicines piggybacking onto proteins to get to certain areas. Okay, this is where that happens. The presence of protein, the presence of fat molecules in the blood can put the drug molecules out of commission if there's too much fat. So anyway, we got to think about what can impact distribution. So again, we're talking about adequacy of blood circulation. Protein binding, again, most common is albumin, and so they'd access the carrier. So here it is either bound to a protein or it is a free drug. So if we don't have enough protein in our body, then that drug that's supposed to bind to the protein is out there building up in the bloodstream and can cause a toxicity issue. Okay? If the drug is out there in a free state, an active state, then the goal is to get that drug to the targeted site as quickly as possible. So again, blood adequacy of blood circulation is going to be very, very important here. Blood-brain barrier. So what that is the brain has a barrier that protects the central nervous system from unwanted substances to get into that area, okay? And it's composed of capillaries with tight walls, with no pores, and surrounded by a sheath of connective tissues. So, it keeps unwanted substances and drugs out of there. And actually, when you read about drugs, sometimes it'll say they cross the blood-brain barrier, or they cannot cross the blood-brain barrier. Okay, drugs that are lipid-soluble or that have a transport system can cross the blood-brain barrier. If they can cross the blood-brain barrier, then it will affect the central nervous system. And so we got to think about that. What kind of effects will it have on the central nervous system? Pregnancy and lactation. Again, you'll see medications that it tells you they can cross the placenta, and they sometimes need to cross the placenta to be effective. Sometimes, though, we don't want medicines to cross the placenta, and so we got to be aware of that, especially in individuals who are pregnancy or who are in childbearing age. Remember our pregnancy classifications too on that. Lactation means that it can enter the breast milk for individuals who are breastfeeding. So again, you'll see that when you read about each of the drugs. Okay, metabolism. The metabolic process is the method by which drugs are inactivated or biotransformed to an active form by the body. Okay, and when we think about metabolism, it is the set of chemical reactions that happen in living organisms to maintain life. But with drug metabolism, it's where the drug chemically breaks down to become either an active or inactive metabolite. And it's, getting ready. The next phase is excreting, getting out of the body. Okay, so it's getting ready to be excreted. Now, metabolites are the products that occur once a drug is metabolized. If you will, think of it as the end product. Okay, an active metabolite continues to exert its intended purpose, then metabolizes further, and then is excreted. An inactive metabolite is ready for excretion. Okay? Now, metabolites can be harmful to the body, and we got to think about that. And if a person has issues with the liver, because the liver is our main place of where medicines are metabolized, then we can have issues with a slowing of metabolism or metabolizing of the drugs. We can have a buildup of those active and inactive metabolites, and they can be harmful. So side effects and adverse effects and toxicity can occur in the metabolism phase of pharmacokinetics. Prodrugs are inactive until they are metabolized, and then they become active. So with these drugs, the distribution of the drug takes it to where it will be metabolized first, and then it starts doing its work. Okay, so most drugs are lipid soluble, which means it gets to the cell quicker, but lipid soluble can't be excreted by the kidneys, so part of the metabolism is to convert the lipid soluble drugs to water soluble drugs so that it can be excreted through the kidneys. Bowel transformations that take place in the liver are performed by the body's busiest proteins, its enzymes. Every one of your cells has a variety of enzymes drawn from a repertoire of hundreds of thousands. Each enzyme specializes in a particular job. Some breaks down molecules, while others link small molecules into long chains. And so, enzymes, they're very, very busy. Now, with drugs, the first step is usually to make the substance easier to get rid of in the urine. So many of the products of enzymatic breakdown, which are called metabolites, are less chemically active than the original molecule. So a lot of times you'll hear the liver referred to as the detoxifying organ because it takes care of all that. However, drug molecules can have chemical activities of their own, and they can be as powerful as those of the original drug. So when prescribing certain drugs, doctors must take this into account with these added effects. Once liver enzymes are finished working on a medicine, the now inactive drug undergoes its final stages of its time in the body, and excretion is the next stage, either through urine or feces. So once again, side effects can occur. Don't want you to forget about that, okay? Side effects can occur. Drug toxicities can occur in this stage. Okay, more on those enzymes. They're located in the liver, the kidney, blood cells, plasma, lungs, GI tract. Okay, so enzymes are catalysts that help cells to help carry out many functions in the body, and they also help with drug metabolism. Factors that affect drug metabolism, we have enzyme induction and enzyme inhibition. So you got some enzymes that will literally get the drug moving, get them going with their actions and that kind of things. They work by stimulating the liver, and drugs can increase the rate of its own metabolism, or the enzymes can help with that. Induction of drug metabolizing enzymes can also accelerate the metabolism of other drugs used concurrently, and so there may be a need to increase those dosages of those. And then there are some enzymes that are considered inhibiting, and so they actually cut off the action of certain chemicals in specific drugs, and they're intended to do that. Okay, and then our final stage is excretion. Okay, and it requires adequate function of the circulatory system, kidneys, bowels, the lungs, and the skin. And so we're basically getting out of the body here the drugs, and some excreted medications will be unchanged or as metabolites. Some are excreted in the urine, some in the bile or feces. Lungs remove any kind of inhaled substance. So drug excretion is described as the removal of drugs from the body. Again, the urine, bile, sweat, saliva, breast milk, and expired air are ways that gets out. Probably your most important organ here for drug excretion is going to be your kidneys. So you got to think about if a patient has renal failure or kidney failure, both the duration and the intensity of drug responses may increase because that keeps the drug longer in the body. So we can experience side effects because of that. We can experience toxicity because of that, of drugs. So we got to always keep that in mind, and that's going to involve our assessment of the patients and their renal function. When we think about urinary excretion of drugs, there's three processes. We have the glomerular filtration that goes on, passive tubular reabsorption that goes on, and active tubular secretion that goes on. Okay, so that's basically, it has to go through those steps to get out of the body in that excretion phase. Okay, a question for you. Absorption is the transport of drug molecules within the body. True or false? Alright, so if you go back and look at your notes, if you answered true, you got it wrong. So absorption is actually the process that occurs from the time the drug enters the body to the time it enters the bloodstream to be circulated. Okay? Distribution is the transport of drug molecules within the body. Okay, so now let's talk about, we're taking this medicine and it's in our body, okay? One way that we monitor for therapeutic effects is through serum drug levels, serum meaning the blood. And that's a laboratory measurement of the amount of drug in the body at a particular time. Now, serum drug levels can be done on any drug that a person takes, but you're only going to see this for drugs that can cause us some major issues. It is not every drug. That would cost a fortune to do. It is an expensive test to do. But you'll see it done for certain antibiotics that are really hard on the kidneys. You'll see it for seizure medications that people take to control seizures. You may see it for drug overdoses. You may see it for, like opiates and that kind of thing. That's a time when serum drug levels are done. So it's not every drug. You'll know when we talk about it as we go through those units of which drugs are done. But it is a way for us to determine dosage and absorption. It's a way to determine the bioavailability of the drug, the amount of drug dosage available to act on the body. It's a way to determine the half-life of medications, and what we're talking about there with the half-life is the time required for the serum concentration of a drug to decrease by 50%. Okay, so you'll see this listed in pharmacokinetics of all the drugs. It'll give you a half-life. The higher the half-life, the longer the drug is staying in the body, which means that makes us more susceptible to toxicity and side effects. So I'll give you an example. Phenobarbital, which is an anti-seizure medication, has a half-life of 50 to 140 hours. That's a long time for a drug to be in the body like that. Okay, so we typically like to see shorter half-lives. Okay, the shorter the half-life, the shorter it's going to be in the body to do the action. Okay, the longer the half-life, the more potential we have for problems. Okay, also serum drug levels can help us with knowing the rates of metabolism and excretion. So the minimal effective concentration, the MEC, must be present for efficacy, meaning efficacy is that it's working as intended. Okay, so we know that certain drugs, they'll have a normal value of what we want to see in the patient's blood. Okay, so we do the serum drug levels to check that, to make sure it is therapeutic. Okay, toxic concentrations are excess drug levels in the bloodstream, and that can be caused by single large doses or repeated small doses, slow metabolism of medications, or excretion, or for that matter any part of the pharmacokinetic phases that can present an issue, can cause toxicity. Okay, receptor drug therapy, or receptor theory of drug action. Okay, so let's study this a minute. This is where drugs exert their effects by chemically binding with receptor cells through activation or inactivation or alteration of intracellular enzymes. It can changes the receptors can change the permeability of the cell membrane to one or more ions. It can have a modification of the synthesis, release, or inactivations of neurohormones or neurotransmitters, or they can act as agonist or antagonist. So let's define those bottom two words. Agonist. Agonists are drugs that produce effects similar to those produced by naturally occurring hormones, neurotransmitters, or other substances. Okay, and you may see some drug classifications saying that this particular drug is an agonist. So when you hear that, that means it is acting similar to what is already in the body. An antagonist, on the other hand, is the opposite. Okay, it inhibits cell function. It antagonizes. Okay, it blocks. So it's an antagonist, and again, you will see medicines classified in this way. Okay, and this is just a picture of this whole receptor theory concept. And you might want to think as a receptor is described as a lock and to which the drug molecule fits as a key. Okay, and you can see only specific keys work in certain receptors. So you see you got a triangle one, you got a circular one there. Okay, so only certain ones will fit into the keys, into those receptor sites. The molecular site, or the docking port of the surface, is, or within a cell, usually involving protein that are capable of recognizing and then binding with those specific cells and drugs. Okay, non-receptor drug actions. There's relatively few drugs that act in this manner, and these include antacids and osmotic diuretics, several anti-cancer drugs, and metal chelating agents. So antacids, the way they work is they change the pH of the gastric acid, so there's no need to attach or be distributed because it's meant to work right there in the stomach. Osmotic diuretics increase the osmolality of the plasma, which pulls water out of the tissue into the bloodstream. So again, there's no need to attach to anything. Chemo, anti-cancer drugs, structurally similar. Some of them are structurally similar to nutrients needed by the body, so they don't have to hitch a ride. The body already uses those nutrients and for cell function, so the body doesn't realize the difference and treats those anti-cancer drugs as parts of the body. So it kind of tricks the body, so to speak. And then the metal chelating agents, what those do is they combine with toxic metals in the body to get them out. For example, lead. There's medications that you'll study about that is a chelating agent, and it gets the metal out of the body. So there's no need for it to attach to anything other than the toxic metal. Now, let's talk about drug-related variables. So first, let's talk about dosage. When we think about dosage, we notice, hopefully you've noticed, that not all medicines have the same dosage, and this can be confusing to patients. I've had patients say this to me a lot. So, let's say that we're on an antibiotic of amoxil, 500 milligrams. And then we have another dose of a cold medicine of some type that is 20 milligrams. Okay, so they're all going to be different. And we need to be sure to teach the patient. I've heard patients say, well, golly, I've got that 500 milligrams. I think I'm taking way too much because my other medicine is 2 milligrams. And you have to explain each medicine is different and the way they're composed of things. And there's no similarity with dosages among medications. Okay, so we definitely got to teach patients about that. The number of doses or frequency is how often we take the drug in a 24-hour period, and it's given a specific way to keep that therapeutic level in the bloodstream maintained. So we need to teach, again, the patients that because sometimes they monkey with that. They kind of treat themselves and say, like, oh, I don't need that medicine now. But we got to explain, you got to take it as it's prescribed because that's how it works. Now, listen, medicines go through a heck of a lot before they're ever approved for human use. And so this is, during those trials, during that research, that's where they figure all of this stuff out. That's where they figure out the dosage. That's where they figure out the frequency. So that's, that we need to explain to the patients, hey, do this, take it as it's prescribed unless we're having some kind of problem. And of course we want to know about that if there's problems. But okay, Loading dose and maintenance dose, sometimes you'll see that with medications like your Zithromax. If you've ever taken that, it gives you one pill to take, which is a little bit higher dosage a lot of times. So you got a loading dose, and then you start taking your medication as prescribed as your maintenance dose. Okay, so sometimes you'll get a loading dose, which is typically a higher milligram, and then it's kind of to give it a jump start. Okay. And so then you're maintained on a different milligram of dose. Okay. Route of administration obviously is going to be huge. We've already talked about that. That influences both absorption and distribution. Remember that your IV, sublingual, inhalation, those are your quickest routes. So definitely that's going to be a huge part as far as the route of administration. Drug-diet interactions can play a big part. Some meds are given to exert a direct effect on the diet, such as weight loss medicines. They can keep fats from being absorbed. Your cholesterol medications that are intended to decrease the serum level or blood level of cholesterol, it decreases cholesterol absorption, so that we take in with our food, with our diet. Other medications are affected with absorption due to diet, and we got to keep that in mind. Each med's going to be different. Some will say it's okay to eat with this medication, meaning you can take the medicine with a meal. As some medications say, you can't eat with it. It's going to affect absorption. Each medication is going to be different, so we got to pay attention to what that says. When it says not to eat, then you can take the medication 1 hour before meals or 2 hours after the meal. So that's crucial. Need to know that. It's one of our duties is to teach the patient about this as well. And so we got to teach them to take it where they will have the best results. Now, you're going to find that most medications will cause some kind of GI, gastrointestinal upset, nausea, vomiting, that kind of thing. And a lot of times you'll see with medications, if the nausea happens, take it with food, even though it will affect that absorption. But we need to try at first, if we can, to take it. If it says to take it without eating, we need to try at first to see if they can do it without becoming sick. Other meds are impacted by what we eat. So one type of antidepressant talks about in your book, MOAs. Those require patients to avoid certain foods with thiamine, such as wine, aged cheese, or beer, because it can cause a reaction, and it can cause severe hypertension. Another medication, warfarin or Coumadin, it's a blood thinner. When the patients take these medications, they have to limit their leafy green vegetables, foods that have a high amount of vitamin K in it, and it can decrease the effects of the warfarin and cause blood clots. Milk products, a lot of those don't work well with tetracycline and antibiotics. Grapefruit is being found to mess with one of the enzymes in the liver that's used to metabolize many drugs. So it can cause toxic level of certain drugs. Statins are an example of that. And statins are medications that help lower cholesterol. It can also decrease absorption of certain medicines, causing a delayed response, and can decrease certain levels of medication. And I have a pictogram just to show you about that. Grapefruits indicted on drug tampering charges. So these little pictures, I love them. But they can be helpful to help you remember things. But I just wanted to show you your, where medications can definitely be involving the drug diet. And this is an example of that. Now, drug-drug interaction is our final one when we're talking about drug-related variables. And it's a very, very, very common situation that occurs, and we've got to keep this in mind with medications, because here's the thing. Typically, patients are not just taking one medication. Typically, they're on many medications. And so interactions with drugs can definitely increase therapeutic effects, but they can also cause adverse effects as well. So if you look at page 25 in your textbook, you'll see the additive effects, synergism, interference, and displacement concepts there when we're talking about drug-drug interactions. So additive effects is when two drugs with similar actions are taken, such as alcohol and sedatives. Okay, alcohol is a drug, by the way. Both of them depress the central nervous system, so that means the patient's going to have an additive effect. And that's not a good thing, especially when we're talking about sedation. Synergism occurs when two drugs with different sites or mechanism of action produces greater effects when taken together. So it gives you an example of acetaminophen along with an opioid. So acetaminophen is like Tylenol, okay? That helps the pain relief in patient to have both of those medications mixed together. Interference is when one drug with the metabolism of a second drug. Okay, so in the liver we have those special enzymes that metabolize certain drugs, and it'll break down certain drugs. So it's almost like they're competing when they get to the liver. And who's going to win. Okay, so you're going to possibly have an interference going on. And then displacement, that's a drug with a strong attraction to protein binding sites that may displace a less tightly bound drug to the protein. Okay, so we can have drugs that can cause that displacement. It gives you a good example in your book there about aspirin and a blood thinner. So aspirin can displace warfarin, which is a blood thinner, and it can increase the drug's clotting and anticoagulant effect. Okay, so we want to be really careful with that. Displacement we want to avoid. Continuing on with drug-drug interactions, we can have interactions that drug effects are decreased, including antidote medications. Now, antidote medications are really important when we suspect a toxicity of a medication. So antidote medications are used when we have too much of a drug. It's an antagonist. It goes against the action of the original drug given, so it counteracts the effect. Okay, and that can come in really, really handy when we have an overdose of a drug going on. Drug effects are decreased, include a decreased intestinal absorption of the drug and and increase metabolism rate of the drug as well. Now, patient-related variables include the following. So, age. Let's talk first about that. Our most vulnerable population of patients are our older geriatric patients and our younger children, pediatric patients. Okay, they are the most vulnerable. So let's talk about why. First off, let's talk pediatrics. So some things you need to know. Everything in the pediatric patient is underdeveloped, particularly up to age 2. So absorption, distribution, metabolizing, and excreting are all affected. Absorption, so let's talk about that. Pediatric patients' stomach acid is more alkaline than an adult, so that can affect the absorption of the medication. Shortness in the intestinal tract, frequent diarrhea, vasomotor instability, and decreased muscle tone. Those all can affect absorption. For muscle tone, decreased muscle tone, IM injections, those are going to cause issues with absorption of that. Underdeveloped epidermis for sub-Q administration will be affected for sure. Okay, now the distribution of meds are also affected. Higher percentage of water in neonates and infants causes a dilution of medication. So in this instance, sometimes with certain medicines, especially water-soluble medications, the pediatric patient may actually need a higher dose than the adult. It's a rare thing, but that does occasionally happen. Less body fat, immature liver, that can cause, problems with our distribution. Metabolism, the immature liver, and the lack of liver enzymes that help metabolizing meds. And then, of course, excretion, the renal function and biliary function is slower, not readily formed up until age 2, so that can affect the excretion. Now, geriatrics, 65 years and older, all organ function, we're talking kidneys, liver, cardiac, respiratory, endocrine, central nervous system, etc., begins to slow down. And all areas are affected. So absorption in the GI tract, there's a decrease in acidity, a decrease in the blood flow, and a decrease in the movement and the motility of foods and things in the stomach going on through the GI tract. Distribution, we have a decrease in the levels of albumin protein, decrease in the body mass, decrease in body fat, increase in body fat, a decrease in the body water, a decrease in cardiac output, decrease in blood flow. So that can all affect the distribution. For metabolism, a decrease in that liver function and blood flow and hepatic enzyme function. And then for excretion, we have a decreased renal function and decreased urination. Also common with geriatric patients is their bowel function. Some have diarrhea, some have chronic constipation. So older people will say, I hate talking about my bowels. It seems like that's all I talk about these days. Okay, also they'll have a decrease in the drug receptors and neurotransmitters. So age-related changes to the body and to the central nervous system, such as a decreased blood flow and deterioration of the blood-brain barrier, occurs as well. So that leaves our geriatric population susceptible to more adverse reactions than any other population. Okay, genetics. Genetics, we are all different because our genes, so how one person responds to a drug may vary from another. That's why we should never take anybody else's medications, or one reason why. So genes deal with the types and amounts of proteins produced in the body cells, so you know what they mean, what that means. It deals with how the drug will react inside of our body. Genes may affect the drug metabolizing enzyme in the liver, so that will affect metabolizing. I think we're going to see more and more work in the genetics and on gene therapy and things like that with medications, and that's going to be exciting to see. Ethnicity, there's definitely ties here, and it should not be ignored. For example, some ethnic backgrounds metabolize drugs quicker than others, and so it will change the way the medication is prescribed. Your text will definitely give you information about that when you study each of the drugs. Also, gender, that's important and should not be ignored. Again, your book will give you differences on when gender-specific changes or related variables are involved. Your pathological conditions are known as the patient's medical history. So that definitely affects drug actions. You've already heard some of them. If a person has a cardiovascular issue, they may have a blood flow issue to get the med where it needs to be to work. If they have a gastrointestinal issue, it may affect absorption. If they have a hepatic issue, it will affect metabolism. If they have a renal kidney problem, it'll affect excretion. Other problems, thyroid problems, okay? And that's a common disease in our area. That affects the metabolism of the body. So therefore, it's going to affect the metabolism of drugs. So when somebody is hypothyroidism, that means that metabolism is slowed in the body, which means it will slow metabolism of the drug. If someone is hyperthyroidism, that means that the metabolism is sped up, and that means that it will shorten drug action and speed excretion, not getting a therapeutic effect. We also have to look at psychological effects, and in this part, the book discusses placebos, and you mostly only see that used in clinical trials for examining, how medications work in the research part. But it used to be a common thing for abusers of drugs. Physicians would prescribe a placebo, and the patients would be told they are receiving something for pain, and it would be a placebo. So you don't see that practice these days due to the ethics involved in that and major emphasis on pain management. So just so you know, that's one use of placebos that used to be in practice. Other psychological effects can involve and can be a patient-related variable, patient depression. So that might involve, the whole taking of the medication, being compliant. Mental illnesses, some mental illnesses, patients don't want to take the medication because of the side effects, and it changes and alters that psychological effect. Anorexia definitely is going to, affect your absorption of medications. So we have to realize psychological effects definitely are a part of this patient-related variables. Tolerance is when the body becomes accustomed to a particular drug over time and a larger dose becomes needed to accomplish the therapeutic effect. This happens with a lot of drugs taken to chronic issues. Cross tolerance is when a person has developed tolerance and they take another drug of the same properties and they have the same tolerance effects. So sometimes taking another drug in that same family does not help. Sometimes it does, but sometimes it doesn't. Now, adverse effects, very important, and these are things that you will become most familiar with. So if you look on your book on page 29, box 2.4, you must know these. Absolutely must know these, okay? So adverse effects are any undesirable response to medication administration. Now, sometimes we have adverse effects that are expected. Sometimes we have adverse effects that may occur, okay? If you've got an adverse effect listed with your medications, it's because they became evident during the research of the drug to make the drug while they were studying it to make the drug available for humans. Okay? So, I always say if if anybody really read those adverse effects, nobody would take anything. Because when you look at adverse effects, and I encourage you to just flip through, go to chapter 10 and look at immunizations, or 15 with corticosteroids. I mean, all drugs have adverse effects. Okay, and we have to know them because we've got to know what to be watching for. We got to know them because if we read these adverse effects and it says, well, it could cause a dysrhythmia of the heart, well, wouldn't we want to know that the patient doesn't have a dysrhythmia before we start the medication? So many times we've got to know these so we will be sure the patient doesn't have something going on before we start that medication. Okay? So baseline assessment has got to be done. It can occur with usual therapeutic dosing. It is more likely to occur or be more severe with higher doses. And again, we talked about the more drugs that you put together, multiple drugs, then we can definitely have issues there. Also, adverse drug reactions, your black box warning. Remember, we talked about that in chapter 1. So those are your serious adverse effects that have happened with your black box warnings. You've got to know those when you study your drugs. So look through those pages. Look through that page 29. You, again, must know those. Hypersensitivity is a biggie because that's an allergic reaction to a drug, and so we've got to ask patients about their allergies to drugs always. Okay, so know your adverse effects for sure. So, toxicity, drug overdose. That's when we got too much drug in the body, and it can come from an excessive amount of medication. It can come from damaged body tissue. Can be both in adults, pediatric populations. It can happen to anyone. I've actually had the hypersensitivity happen to me, so it knows no age limit. Toxicity and drug adverse reactions can happen to anyone. Okay. It may result from a single dose, large dose, or a continuous ingestion of smaller doses. It can and involve alcohol, prescription, over-the-counter, or illicit drugs. It can definitely be a medical emergency, regardless of the location. It can also occur when there are problems in any of the stages of the pharmacokinetics, okay? Absorption, distribution, metabolism, and excretion. So our main goal for toxicology or drug overdose is, if you look at your book on page 31, box 2.5, looking at those. But I want to initiate you to this saying, your ABCs, okay? ABCs are: A is for airway, B is for breathing, C is for circulation, okay? Your ABCs have to take place when caring for drug overdoses or toxicology. So we're going to make sure they're breathing, their airway's clear, we're going to make sure they're breathing, and we're going to give them CPR, okay? So for circulation. So that's going to be very, very, very important. We've got to start as soon as after the ingestion, as soon as we know about it. We got to support and stabilize that vital function, and that's where our ABCs come in. We got to prevent further damage, and so that's done by reducing absorption. So sometimes you'll see them put in an NG tube, nasogastric tube in the stomach. They'll give activated charcoal that affects that absorption of the medication. They may increase elimination, so they may give them something to help them poop over the moon, if you will. And then, if available, they will administer an antidote. So one of our most common antidotes that we use, unfortunately, is because of narcotic overdoses or opiates, scheduled 1 heroin drugs, and that is the naloxone or Narcan. Just on the news this past week, or last week maybe, talked about one city, policemen are now carrying naloxone with them. Firemen are now carrying naloxone with them. I mean, naloxone is going to be as available as our automatic defibrillators that are in places, because that will reverse opiate effects, overdose effects immediately. And that dosage is the nasal inhalation kind. So antidotes are important, and it's very helpful when we know what the medicines take that's overdose, so that we can see if there is an antidote. But first, you got to do ABCs. Okay, this is something that we need to teach the patients about, and especially parents about, for children. The Poison Control Center, and anytime there's children have taken medicines by accident or that kind of thing, or any kind of poison for that matter, they can call this. So this is an important part of our nursing role. Okay, I know this has been really long, but it is an important chapter, and I hope you have enjoyed this podcast.